Hola and good morning, and a very warm welcome to all of you to this oral late breaker session. It's entitled Recent Developments in Antiretroviral Therapy. It promises to be very exciting. I'm Chloe Orkin, and my co-chair is the very eminent Professor Dan Koritzkis from Harvard. We have 6 talks and hopefully lots of time for some very good discussions because they're very interesting. Without any further ado, I would like to welcome Hilke Waleveen, who is a PhD student studying pediatric HIV pharmacology, and he'll be speaking about the pharmacokinetics of dolutegravir 5 mg dispersible tablets in children weighing 6 to 20 kilograms. Hilke.
Not sure how to get out of this, but right. So first of all, thank you very much for introducing me, and also thank to the organizing committee for choosing our abstract and having me present in front of this audience. So my name is Hilke Waleveen, as you said. These are my disclosures. In order to support the registration of the 5 mg dispersible tablet formulation, we set out to perform a PK sub-study nested within the Odyssey trial. Odyssey is a randomized non-inferiority trial evaluating efficacy and safety of first and second line dolutegravir-based ART versus standard of care in HIV-infected children. So initially we set out to enroll 700 children, all above the weight of 14 kilograms. And they were all taking film-coated tablets initially. But as we got along in the trial, we started also to look at dispersible tablets, and we decided to enroll an additional 80 children below the weight of 14 kilogram. And this recruitment is still ongoing. So dispersible tablets were given in Odyssey to children below 25 kilograms. And this table shows you the amount of dispersible tablets they received, dispersed in water, and the total amount of dolutegravir they received daily. So some of these weight bands are in gray and some of them are in orange. And the orange weight bands are part of this presentation and the gray ones are not. For the 3 to 6 kilogram weight band, this is because they haven't been fully enrolled, but we're still enrolling them. And the 20 to 25 weight band has already been presented at CROI earlier this year. So that leaves us the 6 to 10 kilogram weight band, the 10 to 14 kilogram weight band, and the 14 to 20 kilogram weight band, receiving 15 milligrams of dolutegravir, 20 milligrams, or 25 milligrams, respectively. It's good to keep in mind that the dispersible tablets are actually 1.6 to 2 times more bioavailable than the film-coated tablets. And in our PK sub-study, we aim to achieve pharmacokinetic parameters comparable to adult reference values. And in the table below, you see the adult reference values. So by minute, all 50 milligrams film-coated tablets taken once daily. These PKs were done fasted. And 50 milligrams film-coated tablets taken twice daily. And these were done fasted and non-fasted. So our primary target was to see trough. And we wanted it to be comparable to adult data on 50 milligrams film-coated tablets taken once daily by adults. And we wanted the individual levels to be above the EC90 value of 0.32 milligrams per liter, and or the IC90, the in vitro IC90 of 0.06 milligrams per liter. The Cmax was compared to adult data on 50 milligrams taking film-coated tablets twice daily, and the AUC was compared to both to data on once daily and on twice daily. And while we look at Cmax and AUC, it's really the C-trough that is our primary target, as it correlates best with efficacy and is also identified by the regulatory authorities as the primary target to target. Our PKs were done at steady state, which meant that dolutegravir dispersible tablets were taken for at least seven days. And because taking dolutegravir with food increases absorption, and we wanted to mimic a worst-case scenario, we did all of our PKs as much fasted as possible. And for the children above 10 kilograms, that meant that an overnight fast was preferred, but a minimum of 3 hours fasting was mandatory. And for children below 10 kilograms, we did not think it was ethical to force these children, which we thought would be mostly very young children, to fast. And that's why we were a bit more lenient, and we said a 2-hour fast pre-dose and a 1-hour fast post-dose is preferred, but not obligatory. However, we did observe that all but one child was able to fast successfully. And then our results. We enrolled 41 Black African children from Uganda, Zimbabwe, and South Africa. 34 of those children had evaluable PK curves, and 7 did not, due to the various reasons listed here. And the table on the bottom shows you the amount of participants that we got in each weight band. These numbers are slightly bigger than was in the abstract because we continued enrolling when submitting the abstract. So in the end, we got 11 children for the 6 to 10 kilogram weight band, 10 children for the 10 to 14 kilogram weight band, and 13 children for the 14 to 20 kilogram weight band. And median age of the lowest weight band obviously was lowest. And the youngest child enrolled in this sub-study was 6 months old, and the oldest was about 2.5 years old. Then this slide shows you the results, and I'll take you through them. As I said before, our primary target was the C trough, and the 10 to 14 kilogram and 14 to 20 kilogram weight bands nicely hit those targets. However, the 6 to 10 kilogram weight band had C trough markedly lower than our target and had very high variability, shown here within brackets. It's even 167%, the coefficient of variation. When we look at those levels at an individual level, we see that there's the high variation, and we see the geometric mean below the adult reference value. But we also see that 4 out of 11 children had C trough values below the EC90, which was 0.32 milligrams per liter. However, it's important to note that all C trough values were above the in vitro IC90 of 0.06 milligrams per liter. When we go to the 10 to 14 milligram weight band, you see slightly less variation, and as seen in the table, the geometric mean nicely comparable to adults. And for the 14 to 20 milligram weight band, we see geometric mean again nicely comparable to adults. However, we found 2 outliers, and we did look into why these children were outliers, but we did not find a definite answer yet. Going to the Cmax, the 6 to 10 kilogram weight band was very comparable to adults taking film-coated tablets twice daily. However, the 10 to 14 kilogram and 14 to 20 kilogram weight bands had Cmaxes considerably higher than that reference value. Again, looking at those levels at an individual level, the geometric mean of the 6 to 10 kilograms is nicely comparable to our reference, but had high variability. And in children in 10 to 14 and 14 to 20 kilograms all came out with a Cmax above the adult reference value except for one child. AUC in all weight bands was between adults taking the film-coated tablets once daily and twice daily. Again, highest variability was seen in the 6 to 10 kilogram weight band and lower in the other two. This is a very interesting slide. It shows the Odyssey and impact data compared to each other. And first of all, we'd like to thank the impact team for sharing their data and making it possible to present this slide here. Impact data was previously presented at CROI and is shown here in green, and next to their Odyssey counterparts. And perhaps most interestingly is their, they had the same weight bands and dosing with the same number of dispersible tablets. Perhaps most interestingly is the impact 6 to 10 kilogram weight band. They show very high variability, have a similar number as we do. However, their geometric mean is very comparable to adult geometric mean, to our reference, and the one in Odyssey is not. Moreover, Odyssey shows 4 children below the EC90 value, where the impact trial has only 1 child below the IC90 value. And both the Odyssey and impact data will be gathered, and PK modeling study will be done with those data, both sparse data and intensive data for the impact trial, and only the intensive data for the Odyssey trial. And those will be also submitted for the FDA and EMA submission, along with the non-compartmental data that I'm showing here now. So that brings us to the discussion and conclusion. Dolutegravir dispersible tablets in children weighing 10 to 14 kilogram and 14 to 20 kilogram dosed once daily in WHO weight bands achieved similar seat trough to adults. And children in the 6 to 10 kilogram weight band had lower geometric mean seat trough, more frequent seat trough levels below EC90, and PK profiles showed high variability. High variability was seen in both Odyssey and Impact P1093 trials, especially in children below 14 kilograms. And further PK data collection in children 3 to 6 kilograms is ongoing. All children in Odyssey are being followed for safety and efficacy, and Odyssey and Impact P1093 PK data will be included in the submissions to FDA and EMA, so both in the modeling study as the non-compartmental analysis. And Odyssey PK data show that 2 dolutegravir formulations with simplified weight band dosing can be used across the pediatric age range. And to back up this last statement, I would like to show you this graph. It shows you all of our weight bands compared to and their seat trough, so our target and these are all the weight bands we've done to date. I'd like to acknowledge the PK participants in the Odyssey trial, the sites and investigators, colleagues at Radboud and in London, the trial management team, trial steering committee, the IDMC, the Penta management team, Viv and Milan, and the Impact P1093 investigators again for sharing their data. Thank you. Are there any questions?
Thanks for that excellent presentation and for keeping to time. I see somebody at the mic in the middle. Could you please introduce yourself?
It's not on? Jay Lalazar here from San Francisco. Mic is on now. I'm wondering if your data, and congratulations, that's incredible work, whether it creates the possibility of continuing to use 3 drugs for the kids with the lower weights, below 10 kilograms, but that as we're seeing in the adult treatment paradigm, the possibility of shifting to a 2-drug regimen to kids who are above 10 kilograms.
We didn't look at the backbone here, but I would say that in those 2-drug regimens, I guess the dolutegravir is also the most important drug in that. So I would think that this is at least enough data to go ahead and look at that.
Okay, thanks.
I don't see anybody else at the mic at the moment, so could I ask you, in terms of the differences between the IMPACT study and your study, I know it's small numbers, but were there any differences in sex at birth that could account for the differences in variability seen, you know, whether they were male or female children, and whether that made any difference? Because you had a third of your cohort under 10 kilograms were male. Was it similar in the IMPACT cohort?
I'm not very sure if the sex was equal in the IMPACT trial.
Okay.
Actually, I'm not very sure. Is there anybody from IMPACT, maybe? Oh, that's Justin Green.
Yeah, Chloe. Yeah, Justin Green from ViV. I lead the pediatric program at ViV, and we spent a lot of time with our IMPACT colleagues recently. So the allometric scaling model accounts for both development, maturity, and sex. The sex is approximately equal in that cohort from P1093. It's just worth pointing out, particularly those ones with very low exposure. That's good that we've seen that now, because that allows us to model and understand why they've got that low exposure. The one subject in P1093 was nearly 6 years old with severe malnutrition, so he's really very much an outlier in terms of the typical kind of patient we'd be expecting to see and dose in this group.
Thanks, that's very helpful. I can't see anybody else at the microphone. Were there any failures in the children who had low levels?
We're still doing efficacy studies, but as of yet, these children didn't fail, I don't believe. So we haven't looked at that in length, but we will.
Okay, thank you. Christina?
Yes, Cristina Mussini, Modena, Italy. Since the babies that had a low plasma level of dolutegravir were probably breastfed, and so a lot of calcium because they were taking only milk. Did you look at, for example, if there was some distance from breastfeeding or something like this, or if they were taking formula?
Yeah, we had expected more children to be very low and more children to be breastfeeding, but there actually were some quite a bit older children, and the amount of children that were being breastfed was low in this weight band. And also, again, they were fasted, so they actually didn't have, weren't breastfed at the in the interval of dosing.
Okay, thanks.
Thank you for your question.
I don't see any other questions, so thank you very much for an outstanding presentation. Our next speaker is Professor Jean-Michel Molina, who's Professor of Infectious Diseases at the University of Paris and the head of ID at Saint-Louis Hospital. He'll be presenting on MK8591 at doses of 0.25 to 2.25 QD in combination with doravirine, which establishes and maintains virological suppression through 48 weeks in treatment-naive adults with HIV. Jean-Michel.
Thank you, Chloe. Good morning, everyone. It's a pleasure to be here and this very interesting conference in Mexico, and it's also a great pleasure for me to present to you the results of this phase 2 dose-ranging study with a new drug called Islatravir, formerly MK8591. So as a matter of background, Islatravir, so formerly MK8591 or EFDA, is the first nucleoside reverse transcriptase translocation inhibitor. So that's a new drug in a new class. It's in development for both the treatment and the prevention of HIV-1, and you may have seen yesterday a very nice presentation on the use of that drug for prevention in an implant. In vitro, Islatravir has a more than 10-fold greater potency compared to the other approved antiretroviral agents, and it also has potency against a number of NATR-resistant HIV-1 variants and has a high barrier to the development of resistance. In addition, Islatravir can achieve high IQ with low doses. This drug also has a long intracellular half-life, or nearly 120 hours in healthy adults. So all these attributes provide a lot of opportunity for this drug to be dosed either once daily, once weekly, and potentially even less frequently, once monthly in the future. Doravirine is the next generation NNATI, which has been already approved for the treatment of HIV-1. It has activity against wild type, but also viruses who carry an NATR resistance mutation, the most frequent mutation, K183N, Y81C, G190A, and this drug is also dosed once daily without regard to food and has low potential for drug-drug interaction. Doravirine is also well tolerated with low rates of CNS adverse events and has a favorable lipid profile. So these two drugs have the potential to create a very potent, simple two-drug regimen who may maintain the efficacy of antiretroviral agents at efficacy level that would be comparable to traditional three-drug regimen. This slide shows you two of the multiple mechanisms of action of Islatravir. On the left-hand side, you have the translocation inhibition of the reverse transcriptase, which is due to the ethinyl group on Islatravir. And this inhibition of translocation leads to immediate chain termination. On the right-hand side, and this is due to both the ethinyl group and the hydroxyl group, you have delayed chain termination, which prevent nucleotide incorporation even if translocation of the reverse transcriptase do occur. This is the study design of this phase 2 dose-ranging trial. So this is a pretty busy slide, and I'm going to try to walk you through this slide, starting with the key inclusion criteria. So these were treatment-naive adults with an HIV RNA above 1,000 copy per ml at baseline, with a CD4 cell count above 200 CD4 cells. There was no antiretroviral drug resistance in these individuals, no chronic hepatitis C or chronic hepatitis B. And randomization was stratified by a screening HIV RNA level below or above 100,000 copies per ml. Because this was a phase 2 dose-ranging study, only 30 patients were enrolled per arm. The study comprised three parts. The first part was a double-blind placebo-controlled study where the individuals were randomized to receive islatravir at 3 different doses, in addition to the doravirine and 3TC QD. And the control arm was a combination of doravirine, 3TC, and tenofovir. After approximately 24 weeks in the study, all individuals who achieved the viral load below 50 copies at week 20 were transitioned to part 2, where 3TC was removed from the islatravir arms. And so in the first 3 arms, the patients received a dual combination of islatravir at 3 different doses, and this was still blinded, plus doravirine, while the control arm continued to receive a triple combination of doravirine, 3TC, and tenofovir. But for those few individuals who did not achieve a viral load below 50 copies at week 20, they were allowed to continue on the triple regimen until they reached this less than 50 copies threshold, and then they could transition to part 2. So today I'm going to focus on these part 2 results when people have achieved viral load with a triple regimen and were switched to this dual combination with islatravir and doravirine. So the study objective was to evaluate the antiretroviral activity, tolerability, and safety of different doses of islatravir in combination with doravirine, and to compare these to the triple combination of doravirine, 3TC, and tenofovir for 48 weeks. There were a number of primary endpoints. The first primary endpoint was the proportion of participants achieving a viral load below 50 copies per ml at week 24, and these results were presented yesterday at the poster session. I'm going to show you today the second primary endpoint, the proportion of participants achieving a viral load below 50 copies per ml at week 48 with the FDA snapshot approach. I will show you also the number of participants experiencing adverse events, the number of participants discontinuing study drugs due to AEs, and we will also look at the changes from baseline in CD4 T cell count, the proportion of participants achieving a viral load below 50 copies per ml in an observed failure approach, and importantly also, the proportion of participants achieving a viral load below 50 copies per ml 24 weeks after switching to the dual combination. So this slide shows you the patient disposition through week 48, and you would notice that 4 participants in the high-dose islatravir actually didn't make it to part 2. But eventually, the majority of patients reached week 48. This is a summary of the participants which switched to part 2. You could see that most participants actually switched to part 2 at week 24, but a few here at week 28 and week 36. So in all arms, there were a few participants who did not achieve a detectable viral load at week 24, and they had to be kept a couple of more weeks on the triple regimen before switching to the dual combination. So these are the patients' baseline characteristics by treatment group. You could see that the study enrolled mostly men, pretty young, with a median age below 30 years. These participants were mostly white, but with a significant proportion of Latinos or Hispanic. The baseline CD4 cell count was quite high, above 400 CD4 T cells. And the viral load, as you can see here, was slightly higher in the islatravir arms as compared to the doravirine arm, with also a numerically higher proportion of patients with a viral load above 100,000 copies per ml in the islatravir arms. This slide shows you the primary outcome at week 48 using the FDA snapshot approach. And so these results comprise the first 2 parts. And you could see that overall the response rate was high and similar in the 4 arms, with very few individuals actually having a viral load above 50 copies per ml. To look at these data in more details, the results are presented here. And what you could see in particular is that among those who had a viral load above 100,000 copies per ml, you could see that the response rate in the islatravir arm was quite high. Also in the observed failure approach analysis, again, very high response rate in all 4 arms. Very few individuals met the protocol-defined virologic failure in the study through week 48, only 2 in the low-dose islatravir, 2 in this arm here, 1 with a high dose as compared to 1 in the triple regimen. What's interesting, though, was that none of these patients with protocol-defined virologic failure had a viral load above 200 copies, and in fact, all of them had a viral load below 80 copies. So there was no criteria for resistant testing, and so we don't have any data to present on resistance. This slide shows you the virologic outcomes 24 weeks after the switch to dual combination. And you could appreciate here that in all 4 arms you had a very high response rate. Very few individuals actually presented with a viral load above 50 copies per ml in this analysis. What about the CD4 cell count? Well, as expected, you can see here an increase in the mean change from baseline in CD4 cell counts in all arms with overlapping confidence intervals. In terms of adverse events, you could see that very few participants presented drug-related adverse events, and the proportion was also a little bit lower in the combined Islatravir arms as compared to the triple regimen. When you look at the participants who had discontinued their study drug because of an adverse event, only 2 did that in the Islatravir arm, 1 because of diarrhea, nausea, and vomiting, and the other one because of occult HBV reactivation that led to discontinuation of the study drugs. This slide shows you the most common adverse events with an incidence above 10% in 1 or more of the treatment groups, and you don't see any major differences between the combined Islatravir arms and the triple regimen, except maybe a higher proportion of diarrhea with the triple regimen and a higher proportion of headaches with Islatravir. Looking at lab abnormalities, grade 3 and 4 lab abnormalities when seen in at least 2 participants. Again, very few events here, and no trends in terms of dose-related lab abnormalities with the Islatravir arm. So in conclusion, the participants who initiated this dual combination of Islatravir and doravirine with 3TC and then who switched to the Islatravir and doravirine maintain a high efficacy at week 48 as measured by the HIV RNA level below than 50 copies per ml. And these results were similar to those in the control arm with a triple combination of doravirine, 3TC, and tenofovir. No participants in any treatment group met the criteria for resistant testing, and all protocol-defined virologic failures were below 80 copies per ml. The dual combination of Islatravir and doravirine was generally well tolerated with few drug-related adverse events, and only 2 participants in the combined Islatravir arms were discontinued due to adverse events. And so these results are quite promising and demonstrate that this dual combination of Islatravir and doravirine has the potential to be a potent 2-drug regimen and supports its further exploration in phase 3 trials. With that, I'd like to thank all the participants who were enrolled in the study, all the investigators from the different countries in Chile, France, United Kingdom, and the United States, and I thank you for your attention.
Thanks very much, Jean-Michel, for that excellent presentation and summary of such a very complex data set. I understand that the adverse events that led to withdrawal were related to diarrhea and a hepatitis B episode. But in terms of the 3 serious adverse events that were reported, were any of those drug-related?
Well, no, it was not felt that these serious adverse events were drug-related in the study.
Okay. Do you know what they were, those serious adverse events? Sorry.
Well, on the top of my head, I don't recall exactly.
Okay.
It might be on the footnotes of the slide, so
okay.
I have to
we'll have a look
back.
at those. And then in terms of the patients that the protocol-defined virological failure, was there any deep sequencing done? Because I understand they were below the resistance cutoffs. Is there any plan to look in more detail at them?
Not at this point.
Okay. I can't see...
Because, you know, some of them were close to 80, but a couple of virologic failures also were just at 53 copies, just above the threshold of 50 copies. So very, very difficult to do genotyping in these individuals.
Thanks for the excellent presentation.
Thank you.
The next speaker is going to be Jean van Veek, who is the Global Medical Lead for dolutegravir at ViiV Healthcare. He's going to speak about switching to dolutegravir 3TC, fixed dose combination, FDC, is non-inferior to continuing a TAF-based regimen in maintaining virological suppression through 24 weeks. This is the Tango study. Jean.
Thank you, Chloe, and it's lovely to be introduced by a fellow South African, because usually I'm Jean van Wyk. It's a real honor to be here today to present to you the primary outcome results from our Tango study, which I'm doing on behalf of my co-authors, the study investigators, and importantly, the people with HIV who consented and gave their time to take part in our trial. I'm an employee of ViiV Healthcare. I'm the global medical lead for dolutegravir. So today, when a person gets diagnosed with HIV, we feel that they should start therapy as soon as possible and then, of course, remain on it for a lifetime. And this can be 40 years or longer. As such, it's imperative that we consider potential strategies to reduce cumulative lifelong antiretroviral exposure. And one such a potential strategy is to reduce the number of ARVs that they take down to 2. Dolutegravir plus lamivudine is a 2-drug regimen that's already been shown to be non-inferior to a dolutegravir-based 3-drug regimen over 48 weeks of therapy in the Gemini studies. And we'll hear about the longer-term durability data from those studies from Professor Khan in a minute. That outcome at week 48 led to the approval of dolutegravir plus lamivudine as a fixed-dose combination, also known as Dovato, in Europe and the United States already, with regulatory filings ongoing in other countries. In the Tango study, we looked at what will, the safety and efficacy of dolutegravir plus lamivudine in a stable switch population. So people with HIV-1 infection were eligible to participate in this trial if they were on a stable TAF-based regimen with undetectable viral loads for at least 6 months. TAF, of course, is tenofovir alafenamide, which is a prodrug of tenofovir. They could not have had previous virologic failure or any indication of resistance to either dolutegravir or lamivudine with the reverse transcriptase or integrase. Patients also could not be hepatitis B infected in order to be included in this study. They were then either randomized to dolutegravir plus lamivudine as a fixed-dose combination or to remain on the TAF-based 3 or 4 drug regimen. The primary outcome is at week 48. As is standard now in switch studies, we look at the proportion of participants with virologic failure or viral loads above 50 at week 48, and that's what I'll be presenting to you. So we included 369 participants in the dolutegravir lamivudine arm, and 372 remained on the TAF-based 3 or 4 drug regimen, and this is the intention to treat exposed population. On average, patients were around 40 years old. We had the majority of the participants were male and white. We were disappointed about the low percentage of women included in this trial, but it really is an effect of the very fast recruitment period, which was about 3.5 months. We had about 20% of patients of Hispanic or Latino ethnicity. At baseline, as expected in a switch population on stable therapy, the participants had high CD4 cell counts of around 700 cells. There were very few that had CD4 counts below 350. And the most common baseline core agents were integrase inhibitors. Specifically, 2/3 of the participants were on boosted elvitegravir with FDC TAF as a 4-drug regimen. This was followed by rilpivirine in 12% of patients and boosted darunavir in 7%. On average, these participants had been on their stable first-line regimen for just under 3 years, but it's noteworthy that there were some participants that were on their first-line regimen for as long as 17 years. So what did we find? Well, in short, the dolutegravir plus lamivudine 2-drug regimen arm was non-inferior to the TAF-based 3 and 4 drug regimen arm. And this is true whether or not you look at virologic failure as the primary outcome, or virologic success as one of the important secondary outcomes. So let's look at a bit more detail. There was only one patient in the dolutegravir lamivudine arm that had a viral load above 50 copies at the week 48 snapshot window, compared to 2 in the TAF-based regimen arm. This equates to 0.3 and 0.5% respectively. The difference between the treatment arms was minus 0.3, and this is below, and the upper limit of the confidence interval was 0.7, which is below the 4% non-inferiority margin, once again proving non-inferiority of the two-drug regimen of dolutegravir plus lamivudine compared to the TAF-based regimen. And you can see for virologic success, there were 93.2% of patients in the dolutegravir lamivudine arm that had undetectable viral loads in the snapshot window, compared to 93% in the TAF-based regimen arm. This also shows non-inferiority, as you can see on the right-hand side there. Also to note that in the per-protocol analysis, there were actually 0 patients in the dolutegravir lamivudine arm that had viral loads above 50 at week 48. Looking a little bit more closely at that group with viral loads above 50, that one patient in the dolutegravir lamivudine arm discontinued the study with a viral load above 50 for other reasons. In fact, this patient left their study medication in a taxi after going to the clinic, and the site was not able to contact them again. So they were a protocol violation for non-compliance. In the TAF-based arm, there were 2 participants. Both of these had viral loads above 50 at the week 48 snapshot window. There were 6.5% of patients in both treatment arms with no virologic data. As you can see, discontinuations due to adverse events or death was higher in the dolutegravir lamivudine arm compared to the TAF-based regimen arm, with 12 versus 1 patient in these arms respectively. The death, there was 1 death which was due to a gunshot wound, a homicide, and these adverse events being higher in the dolutegravir lamivudine arm is completely as expected in a switch population where the majority of patients were introduced to 2 new agents in the dolutegravir plus lamivudine arm. One very important way of looking at potency and efficacy is also to look at confirmed virologic withdrawals. In this study, it was defined as a viral load above 200 copies after a previous viral load above 50 copies. And we see that in the dolutegravir lamivudine arm, there were 0 patients with CVW or confirmed virologic withdrawal through 48 weeks, compared to 1 in the TAF-based regimen arm. Because there were 0 patients, of course, there was also 0 resistance development in the dolutegravir plus lamivudine arm. Similarly, in the TAF-based arm, that patient did not develop resistance. So looking at the safety, overall, for any adverse events, the proportion of patients were similar between the treatment arms at around about 80%. Any drug-related grade 2 to 5 adverse events occurred in 17 and 3 patients respectively. All of these were actually grade 2 adverse events. And then adverse events leading to withdrawal from the study was also low at 13 and 2 participants respectively. And when we look at drug-related adverse events leading to withdrawal, it was only 9 and 1 participants respectively. The serious adverse events were comparable between the arms, and none of the serious adverse events were considered to be drug-related in either arm. We also looked at weight, and we see an increase of 0.8 kilograms in weight over 48 weeks in both treatment arms, so no difference there. There were 6 participants in the TAF-based regimen arm that had a weight increase adverse event, compared to 3 in the dolutegravir plus lamivudine arm. These are the individual adverse events leading to withdrawal. You can see that there's a number of AEs here that occurred in single patients. The most common ones were anxiety and insomnia, but that was only 3 patients for each event in the dolutegravir plus lamivudine arm. We also looked at weight as well as bone and renal biomarkers as additional safety assessments. Here you can see outcomes for weight, and we show it by the categories for the most desirable NSEP category, which is shown in green in this multicolored bar. So on the left-hand side, you can see dolutegravir plus lamivudine. For all the individual lipid parameters, you can see an increase in the green bars from baseline to week 48, and that includes the total cholesterol HDL ratio that increased from 40 to 45% for this most desirable category. In the TAF-based regimen arms, the green proportions remain relatively consistent over time, and for the total cholesterol HDL ratio, that was 44% at baseline as well as at week 48. These are the renal biomarkers. As expected, we see an increase in serum creatinine due to the OCT2 inhibition of creatinine secretion by dolutegravir, and concurrently we see a decrease in the estimated GFR when using creatinine. But when using cystatin C to estimate the GFR, we see that there's absolutely no change over 48 weeks in the dolutegravir plus lamivudine arm, and only a small decrease in the TAF-based regimen arm. The urine markers looking at proximal tubular function are also shown here, and you can see that there's little change over the first 48 weeks of this study, with no differences between the arms, and it's probably just a variation around the baseline that we see here. So it would be important for us to continue following up these patients over the 3 years of this study to see if there's any differentiation for this. Similarly, for the bone biomarkers, we also see small changes over the first 48 weeks. Typically, all of these are actually less than 8% from baseline changes. There's movement in both directions. However, we can't really make any clinical assumptions of clinical significance from this data. And again, it would be important to look at outcomes over 96 and 144 weeks to see if this has any clinical significance. Lastly, we also looked at M184V status by doing proviral DNA testing. Just to note that this is a post-hoc analysis of stored baseline samples. We found 4 individuals in the dolutegravir plus lamivudine arm and 3 in the TAF-based regimen arm that had M184V or I in their baseline samples. All 7 of these participants were virologic successes throughout 48 weeks, and in fact, none of them had any viral blips through the 48 weeks. So in conclusion, switching to the fixed-dose combination of dolutegravir plus lamivudine was non-inferior to remaining on a TAF-based 3 or 4 drug regimen through 48 weeks in these antiretroviral experienced virologically suppressed adults. There were no confirmed virologic withdrawals in the dolutegravir plus lamivudine group, with 0 resistance development. The safety profile of the dolutegravir plus lamivudine fixed-dose combination was consistent with what we know for the individual agent and their labels. And these data support the use of dolutegravir 3TC fixed-dose combination as a new robust switch option without an increased risk of virologic failure or resistance, as well as with reduced antiretroviral exposure. Thank you.
Thanks very much, John. It seems the audience is completely exhausted, as nobody can seem to drag themselves to the microphone.
Sure, I have a quick question. Could you remind us what proportion of the participants were on dolutegravir at study entry? Because that would obviously relate to your assessment of the weight change.
Yes, so the majority integrases were boosted alvategravir. There were 9% of patients in both treatment arms on dolutegravir.
Another question, did you do any DEXA scanning in terms of the bone changes?
No, unfortunately, we do not have DEXA scans in this study.
Okay. Joe?
Yeah, hi, Joe Iran. I just have a quick question. I noticed that headache was more common in a drug-related AE, but if you actually looked at all headaches, there was actually, didn't look like there was any difference. So I wonder if you looked at insomnia and anxiety, as opposed to looking at drug-related, just looked at overall insomnia and anxiety without attribution to see if there was a difference between the two arms.
We haven't looked at that yet. This data is hot off the press. It's only 2 weeks old. So we will do an additional analysis for the safety outcomes as well as the efficacy outcomes over time, but thank you.
Andrew?
Andrew Carr, Sydney. Is there any discernible advantage of the switch?
So Well, the main advantage, of course, as I mentioned in my introduction, is that we're switching patients from 3 or 4 drugs to 2 drugs. So hopefully over a lifetime of antiretroviral therapy, when we can reduce antiretroviral exposure, there will be an advantage. But the point, yeah, that's the point. We're switching from 3 to 2 drugs. That will have many potential implications, including not just exposure, but things like cost and so on.
Thanks, Jean, for the excellent presentation. I'd like to hand over to my co-chair.
Thanks very much, Chloe. Our next speaker will be Pedro Khan from the Infectious Disease Division at Buenos Aires University Medical School, and he will be talking to us about the durable efficacy of dolutegravir plus lamivudine in antiretroviral treatment-naive adults with HIV infection, the 96-week Gemini results.
Thank you very much, Mr. Chairman. It's my privilege to be here. I would like to thank the organizers for inviting us to present these results on behalf of my coworkers. As John said a minute ago, the requirement for lifelong antiretroviral therapy has highlighted interest in 2 drug regimens to minimize cumulative drug exposure. We presented the primary analysis of the Gemini 1 and 2 study at the last conference, at the IAS conference in Amsterdam 1 year ago, and we showed non-inferiority for the dual therapy combination when compared to dolutegravir plus tenofovir and FTC. And as has been said, this result led to approval of this combination as a once daily STR 2 drug by the US Food and Drug Administration and the European Agency. Now we are presenting the pre-specified week 96 secondary endpoint analysis of Gemini 1 and 2 in order to evaluate the durability after 2 years of therapy with this combination. Just to remind you, patients to be included in this study needed to be naive, have a viral load between 1,000 and 500,000 copies at screening. Nevertheless, we had 2% of patients that at baseline had more than 500,000 copies. They had to be completely naive or having been exposed to less than 10 days of prior antiretroviral therapy. No major reverse transcriptase or PI-resistant mutation was required as an entry criteria. Of note, INSTI mutations were not looked at screening. And obviously, patients had to be HPV negative or having no need for HCV therapy. The primary endpoint was presented last year, and now I am presenting the week 96 results, and this study will go on until week 144. As you may imagine, in such a large trial with more than 700 patients in each arm, randomization took good care of a well-balanced population. Again, this was mainly a white population with a relatively low proportion of females included. And I would like to drive your attention to the 2 red boxes, in which you see that we had about 20% of our population with more than 100,000 copies, and unfortunately less than 10% of patients with less than 200 CD4s. I am highlighting this because this was a criteria for stratification at entry, so patients were stratified based on viral load and CD4 count. Here are the results. First of all, I'm pointing out the 48 weeks results, 93.3 and 91.5 respectively. And when it comes to week 96, 89.5 for the triple therapy arm and 86.0 for the dolutegravir 3TC arm, in which the non-inferiority has been shown, both in the separate analysis of Gemini 1 and Gemini 2, and also in the pooled data. Now, for the sake of clarification, we did also a secondary analysis that was pre-specified, that is the TRDF, treatment-related discontinuation equals failure, which accounts for confirmed virological withdrawal due to lack of efficacy, withdrawal due to treatment-related adverse events, and participants who met protocol-defined stopping criteria. Again, you can see the numbers are very similar in this analysis, 96.6 for the dolutegravir 3TC and 96.4 for the triple therapy arm. Again, in the few cases that we saw in both arms with confirmed virological withdrawal criteria, Zero treatment emergent resistance was seen in Gemini 1, Gemini 2, and obviously in the pooled data. So this is one of the major issues that we would like to highlight in this study. Regarding patients that with more than 50 copies at 48 weeks and 96 weeks, as you can see here, you see the solid lines for the 96 weeks data, and the other bars are for 48 weeks. And as you can see, the proportion of patients at both time points was relatively similar, 3% and 2% respectively. I would like to underscore that discontinuation for other reasons or no virological data were a little bit higher in the dolutegravir 3TC arm when compared with the triple therapy arm. As you can see here, we have 8% in the dual therapy arm at week 96 and 5% in the triple therapy arm at week 96. Proportion of patients with less than 50 copies, by baseline viral load and CD4 count. Here you see below 100,000 copies, nothing special to comment. With more than 100,000 copies, again, we see very similar numbers. With more than 200 CD4s, again, nothing special to show. And as we saw in the 48-week analysis, we saw that in patients with less than 200 CD4s, there was a lower number of patients that could be analyzed in the snapshot FDA window. But when it comes to look at the reasons, we see that at week 96, there were 3 confirmed virological withdrawals in the dual therapy arm and 2 in the triple therapy arm. So the reasons for not being in snapshot here are not related to virological failure. Regarding drug-related adverse events, the overall adverse events profile were very similar, but there was a lower risk of drug-related adverse events in the dual therapy arm. When you look at here, you have 20% against 25%, and this is reasonable because you are using one drug less here. Any serious adverse events, 9% for each group. In terms of neuropsychiatric adverse events, 1% in each group, and headache was again the most frequently seen in both groups. Of note, increased weight, which is an issue of interest in this conference, was seen in about 80% of the participants treated with the dual therapy arm and 14% in the patients treated with the triple therapy arm. And the overall mean change from baseline was 3.1 kilograms in the dual therapy arm and 2.1 in the tenofovir FTC dolutegravir arm. Regarding the change in renal biomarkers, is pretty similar to what has been shown a couple of minutes ago. You can see here an increase in creatinine in both groups, higher in the tenofovir containing arm. The GFR from creatinine, as a consequence, is also higher here. But when it comes to the true GFR that you study with the cystatin C, you can see that the GFR really increased in both arms, but the increase was higher in the dolutegravir 3TC arm. And if you go to the urine markers, you will see a very similar pattern. Regarding change in both biomarkers, again, the dual therapy arm was favored. We don't know the clinical implications of all these changes, but it's certainly not bad news for dual therapy combination. And as you can see, some of the, indeed all of them, achieved statistically significant with a P of 0.001. On the other hand, change in serum lipid at week 96 favors the triple therapy group, as you can see here, for total cholesterol, HDL cholesterol, LDL cholesterol, triglycerides. But when it comes to the total cholesterol, HDL cholesterol ratio, both groups showed a decrease, which is good, but the decrease was better when you kept tenofovir in the regimen. So in conclusion, the durability of dolutegravir 3TC is shown in this presentation at 96 weeks. Low rates of confirmed virological withdrawal through week 96, and no resistant development was seen in either arm. Regarding safety, the overall safety and tolerability were comparable between groups. We saw a lower risk of drug-related adverse events with the dual therapy arm. Change in renal and bone biomarkers significantly favors dolutegravir and 3TC. We see improvement in total cholesterol HDL ratio in both arms. Nevertheless, preserving tenofovir was a little bit better for your lipids. and I think that these results confirm that dolutegravir 3TC is a compelling treatment option for people living with HIV. If you would like to go more in deep in this regarding information about this combination, you have still time to look at the poster 231, in which viral load rebounding including blips through week 48 were presented there, and there's no difference in terms of blips in dual therapy or triple therapy arm. I would like to acknowledge, first of all, the study participants, families and caregivers, investigators and site staff who participated in the study, and the company that produced the product development, and the team members. And this is a large list of contributors in this large study from several countries. I thank you for your attention.
Thanks very much for that very concise presentation. We have lots of time for questions. While people are getting to the microphones, let me start. Pedro, as you highlighted, one of the issues with the 48-week data was the difference in proportion of participants reaching undetectable virus load in the low CD4 count group, but it looked like the participants caught up at week 96.
Yes.
Could you just amplify on that?
Yeah, because indeed there were no cases of confirmed virological withdrawal in this group. So we only, to be perfectly accurate, we had one case that was a confirmed virological withdrawal, but the other cases left the study for other reasons. So.
And another question that comes to mind from these data are looking at the difference in the specified analysis where you were doing the FDA snapshot of proportion less than 50 and the treatment-related failures. It's always a confusing concept for people because everybody uses a slightly different definition of failure. Can you go into that a little bit more?
Indeed, the treatment-related discontinuation failure analysis, there was a pre-planned analysis, and what we try to do is to really sort out if any difference that could pop up in the analysis would be due to would be related to treatment, namely virological failure or intolerance to the study drugs, which in this case was not important. So it's quite similar to the observed data analysis that we see in other observed failure analysis that we see in other studies. A study, an analysis that they did not show because it's not contemporary use, in the last observation carry forward analysis gave us very similar results. So we are very confident that the difference that we are seeing is not based on lack of efficacy or virological failure.
Mike?
Yeah. Tony Mills from Los Angeles. Excellent presentation, Pedro. When you were talking about the renal biomarkers, obviously this is a big issue. This has been a big differentiator for us recently in choosing therapies. I thought that what I heard you say was that there was no difference really between the two groups, but from the slide it looked like there was a better performance in the dolutegravir 3TC arm. Did I misunderstand that, or what was the difference there?
You mean a better performance in terms of virological efficacy?
No, the renal biomarkers.
Oh, yeah. There was, we didn't want to overestimate the results that we see. There was a significant difference in terms of adverse events. The clinical meaning of the differences in the long run, I think that could be important, but we couldn't say, okay, if you keep your patients in triple therapy, your patient will die because of renal disease or will broke any let's say a leg or whatever. So yes, the difference is there. Is the tolerability in terms of drug-related adverse event is better in the dual therapy arm, and that's what it is so far.
Thank you.
Good morning. Mark Hubbard, affiliated with a number of advocacy groups, including Vanderbilt and AVAC. These are exciting results, but I have to express some concern about the lack of diversity in the enrolled population. There was a comment made about speed of enrollment, and I'm not sure whether to take that as a justification or recognition of what needs to be done differently in the future and what kind of commitments are going to be made to improve on that?
I believe that comment was from the previous study.
The comment was from the previous study, but as I recognize the enrollment populations in both studies, I believe that there is a concern. So in general, how can that be addressed?
No, your point is well taken. The issue of speed of enrollment was not the case in this study, that in which it was fastly enrolled, but not extremely fast enrolled. But I agree with you. I think it reflects what we have in the participant side as the main population that is being treated. So we see mainly young people. We see mainly males more than females. And that's what it is. But I agree with you, we need better efforts in order to include more females in the studies.
Next question.
Hi, Lena Sergitas from the University of Toronto. I'm going to echo the comments and go a little bit further. You had, I think it was about 100 females in your study. The same goes for the previous studies. If you have some women in the studies, can you give us some gender or sex-based analysis?
Well, the subgroup analysis will be done shortly. The database was very recent, so we didn't have time to go through the subgroups. But certainly we will do a subgroup analysis, including gender as one of the issues.
Thanks very much. We'll need to move on. The next speaker will be Francois Venter from the University of Witwatersrand in Johannesburg, South Africa, and he'll be speaking about the advanced trial, the phase 3 randomized comparison of TAF FTC dolutegravir, TDF FTC dolutegravir, or TDF FTC efavirenz for first-line treatment of HIV infection. Francois.
Thanks, Dan, and thanks for the introduction. I'm going to be presenting on behalf of a very large team of advanced investigators. The paper was published this morning in the New England Journal, and our full set of disclosures are part of that manuscript. So the integrase inhibitors have taken over from NNRTIs in richer countries over the last 5 or 6 years in almost its entirety. And TAF has come to replace tenofovir steadily in those countries as well. Both dolutegravir and TAF offer toxicity benefits, and certainly when they're licensed generics, which is the case for both those drugs, they provide substantial cost reductions on the traditional efavirenz-based, tenofovir efavirenz-based regimens. Dolutegravir additionally has this amazing resistance profile, and for countries like mine in South Africa and the region where NNRTI resistance is on the rise, and WHO has that magical 10% threshold that they encourage us to move to dolutegravir and away from efavirenz for, it makes it a very compelling drug. So ADVANCE is an investigator-led 3-arm non-inferiority study. We're presenting the 48-week data, which is what's in the NEJM, and some of the 96-week data from the data set. As I'm going to emphasize again and again, the 48 to 96-week data is incomplete, and particularly for the weight and virological data, that's quite important. Michelle has presented the weight gain data in a huge amount of detail on Monday, and I strongly suggest you go and watch that. And I'll just give you a few sound bites in terms of that. And then Nomatemba will be presenting the pregnancy data in a poster immediately after this presentation. So it's a fairly bog standard inferiority study, non-inferiority study, and we randomize patients across the TAF dolutegravir arm to tenofovir dolutegravir and then to tenofovir efavirenz. We used FTC because that was the standard cytosine analog used in South Africa, as well as that's what the Gilead donation came with in terms of the TAF, so we did manage to harmonize that side of things. The inclusion criteria, we recruited these patients from PEPFAR programs in central Johannesburg with relatively limited inclusion criteria, and you'll see why that's important in a moment. And they couldn't have TB or be pregnant, and we did not have baseline genotyping. That analysis is being retrospectively done at the moment. And then we ran them over 96 weeks. That's, again, a fairly common analysis. We used the FDA snapshot methods and powering in terms of the non-inferiority study. And I'm going to talk about the 48-week suppression 50 copies data in a fair amount of detail, because I think there's some interesting lessons to be learned here in terms of future trial design. So in terms of representativity, I think we're okay. You can see the median age there. The demographics reflect the South African and Southern African epidemic very accurately, actually. Our patients were on the heavier side, and Michelle showed data to show that the women were actually ever so slightly heavier than the men, the absolute kilograms. And you can see about 20% of the patients had viral loads over 100,000, and the median CD4 count, these patients were relatively healthy. I think importantly, it's a single-site study, but Johannesburg is this massive economic hub, so we have an influx of people from across South Africa, which is very, very large, and then a huge number of Zimbabweans, and the rest of were from the rest of Africa. So if you look at in terms of representativity, this probably was drawn from a population group which represents a quarter of the global epidemic in terms of its of who's actually in the study. So this is the data, and here you can see the TAF dolutegravir arm. We had extremely rapid virological suppression. Over 90% of the patients were suppressed by 4 weeks, and that viral suppression is maintained. And as I said, that data set is incomplete through to 96, but there's nothing worrying to be seen there. In a very similar way, the tenofovir dolutegravir arm looked very similar and performed very, very well. Very rapid suppression down even by 4 weeks. I think what surprised us is, even though it doesn't look great with the color scheme, but over 90% of the patients in the efavirenz arm, you must remember that this is in the context in central Johannesburg where that 5 to 15 rate is probably close to the 15% rates of NNRTI resistance. Over 90% of the patients were below that 1,000 threshold, and you can see that they all achieved good virological suppression as we went along. Again, this is a fairly standard way of demonstrating the virological suppression, the intention to treat analysis, and you can see that we confirmed, I think everyone's very unsurprised, non-inferiority with dolutegravir. And interestingly enough, we had far more effect of social issues such as age and employment in terms of viral suppression rates. And if you were young and unemployed, you had a viral suppression rate measured in the 60%, and if you were older and employed, your viral suppression rates were almost 100%. So these social determinants obviously playing a large role. If we remove the patients who didn't finish the study, what Charlie Flexner's taught me about called persistence, you can see that actually it's not about virological potency. It really is about efavirenz, probably a side effect profile that seems to be driving these benefits of dolutegravir over efavirenz. As I said, we confirmed non-inferiority, and Andy and his amazing team have told me that we just missed showing superiority, but the primary efficacy analysis, I think, came as absolutely no surprise to anyone. So we had a look carefully to see, is there something different about our study? And as you can see here, we looked at all the dolutegravir studies where they combined it with 2 NRTIs, and you can see that the advanced 2 arms, both the TAF dolutegravir arm and the tenofovir dolutegravir arm, look very similar to similar studies that have been used in registration and other investigator-led studies. Similarly, you can see it with the efavirenz arm. Again, NAMCEL, which is also in the NEJM today, they had far, far higher viral loads, so that suppression rate was actually quite low, and they used 400 milligrams of efavirenz. But you can see that the advanced arm looked very similar to other arms. I just wanted to pause on something that we thought was really interesting. So if you use the classic snapshot 48-week data set here, this is the TAF dolutegravir arm. You can see in the middle column that we had about 18 patients who virologically failed. We didn't switch those patients. All we did was do what WHO tells us we should be doing, which is reinforce adherence, and almost every single one of them suppressed. We had a single failure above 1,000, which to my mind is astonishing when you think that's 350 patients. We have 2 failures in the entire group. And similarly with, again, the tenofovir dolutegravir arm, 19 failures and only 3 in terms of that we weren't able to suppress in the medium term. And again, demonstrating the remarkable robustness of dolutegravir in this situation. Even the efavirenz arm, though, performed really well. We only had 16 virological failures, but there was that issue of persistence, and you can see only 7 patients out of 351 actually failed. And as I said, this is in the context of widespread NNRTI resistance. And the resistance profile is in all the people actually interested in the actual mutations is in the NEJM paper in gruesome detail. We had no dolutegravir emergent resistance. This is a population, by the way, which was the first one to break Illuvia, so we thought we might be the first ones to break dolutegravir, but that was not the case. And within the efavirenz arm, it was the usual smattering of expected mutations. All three regimens were very well tolerated. There was a small number of patients in the efavirenz arm that developed rash, the usual neuropsychiatric stuff, and hepatitis, and had to be removed from the study. And we had, within before I go to that, we pickled these patients in questionnaires because at the time, sleep issues were coming to the fore. We were worried that we'd have to justify dolutegravir to governments when we thought it was going to be more expensive than efavirenz. So we wanted to document very well if there were other social benefits around and other side effect benefits around the use of dolutegravir. But there's absolutely no impact on sleep, on anxiety, and any form of mental health, and very small amount of improvement in terms of quality of life across the arms. It was exactly the same by arm. The other thing, which many of you have probably forgotten, but there was lots of drama about iris and its relationship to integrase inhibitors, and we saw very little iris. And the 3 non-TB iris cases we saw are documented in the paper. We also used a lot, our SOPs mean that we used IPT very aggressively, which is again WHO recommendation. We had almost no TB in the study. And the handful of the 15 cases we had, 10 of them, you must remember this is a very high TB burden zone. The 10 cases of TB out of the 15 total cases actually occurred in the first 3 months, and I think we're probably just failures of screening. In terms of labs, the lab differences, again, were very similar. We saw, as you'd expect with efavirenz, slightly increase in the sort of obstructive liver enzymes, the gamma GTs and the alpha phosphors, but otherwise there was really nothing exciting happening there. We did DEXA scans. Again, we're going to talk about the fat data. I'd love to tell you that I was looking into the future, but we did this to demonstrate the benefits in bone of TAF over tenofovir. We weren't looking at fat, and that was just a happy side effect of having done all those DEXAs. But you can see that tenofovir, as you'd expect, and this is, to my eyes, very similar to the registration studies, had more of an impact in terms of bone density than the TAF arm. At all the arms, there was minimal impact in terms of renal disease, and you can see that there were a handful of cases where we had renal issues, but they were often confounded by the fact that there was another event, such as lupus nephritis or sepsis, driving those. And again, you can see we did the same analyses in terms of tubular markers, and again, tenofovir seems to have more of an impact, a very similar impact, again, as the registration studies on the tubules. So this was the stuff that caught us by surprise, and Michelle, as I said, has presented this to you in detail, so I'm just going to give you a snapshot. This is what happened with the men. The data set's not completed here yet, but you can see a steady rise in weight across the 3 arms, and it seems to be slightly worse in the TAF dolutegravir arm than in the tenofovir dolutegravir arm. But with the efavirenz-based arm causing the least amount of weight. This was what I think really alarmed us, was the fact that in women, the differences were severe. It is important to note that South Africa has an obesity crisis, and in fact, almost half the women entering the study were overweight or obese to begin with. But we took care of the rest of them, I'm afraid, with our drug regimens in the process. But you can see 10 kilograms at 96 weeks on average in the TAF dolutegravir arm, but a significant weight even in the tenofovir dolutegravir arm. Briani, our statistician in the audience, has put together these heat maps which tell the story very graphically, and shows the steady rise in obesity and overweight levels from essentially sucking the patients out of the normal weight into these other categories. We also have DEXA data. And that seems to be sort of equally spread between the trunk and the limbs. We're busy trying to do the analyses on visceral fat to see where the pattern of this fat is actually going. So interestingly, we didn't see anything metabolically. There was nothing across the arms despite this weight gain in terms of blood pressure, lipids, glucose, and it didn't change really significantly by timeline. We didn't do HbA1cs at baseline because we didn't think this was going to be a side effect. So we managed to do them all at 48 weeks, and there's no difference there across arms. We then, the statisticians then looked at it and couldn't correlate it with the stuff that we thought would maybe be confounding this, such as insomnia, hormonal contraception, nausea, mental illness and adherence, and none of this played out in the statistical analysis. People have argued when we've showed you this data behind closed doors that this is a return to health effect. I think that's very unlikely. These patients had C4 counts in the mid-300s. They were doing pretty well, and their viral load decay was very rapid across all 3 arms. I don't think you can, a lot of the patients thought this was a return to health effect, but I don't think you can actually say that. The pregnancy stuff is going to be presented in the poster in detail immediately after this presentation. I'm not going to, but the cohort is relatively small. We're going to follow them up further. We're going to be following the children very intensively in this cohort. So we asked, when the NCMB asked us to reconsent the patients who were on the dolutegravir arm, and we asked them, how do you feel about your weight gain before we did the consent process? So we didn't prime them. And as you can see here, that most of the patients are actually relatively happy with their weight gain. I don't think that means they're going to be happy when they've gained 15, 20, 30 kilograms. So I don't think you should go there immediately. But a lot of patients are actually unhappy due to weight loss, often in their efavirenz arm. And 20 of the patients who we had there gained more than 20% of their baseline weight. Only 2 of them were actually unhappy. So, and importantly, no patients opted to switch. So my final conclusion is the virological efficacy across all 3 arms was actually very high, and social factors seem to impact on resistance decay far more than the actual regimen. And despite this documented background in NRTI resistance, the efavirenz arm did really well. In all the arms, though, just doing a proper adherence intervention got them down to undetectable in most cases. There was very little toxicity. They were all very well, and the benefits of TAF and dolutegravir, the standard of care regimen, were very predictable, other than the weight gain, where we saw greater gain in women, in the dolutegravir arms, and in the TAF arm. And again, people have said this is very different, but when you looked at the average weight gain amongst the men in the study, it was very similar to the registration studies that were used to register here. My final comment is just around the complexity of this for PEPFAR programs and governments which have been pushing very hard to move to dolutegravir for public health reasons and supply line reasons, means to my mind that we are going to have an alternative for people who are gaining weight. And at the moment, the only alternative we have available is this current standard of care efavirenz-based regimen, which creates all sorts of supply line issues. And I think we're going to be stuck with that for the foreseeable future. But reassuringly, the efavirenz arm actually did really, really well. So I'd just like to thank all the usual suspects, and particularly Andy Hill and his statisticians. It's probably a bit unpopular these days, but I'd really like to thank the drug companies. I don't think there was any commercial gain to actually to the study, and they've been towers of strength, firstly donating drug, but also helping us navigate the neural tube defect drama, and now the weight gain drama, and I really need to thank them. But most of all, and I'd really like, this study was a dream to conduct as a PI from the operational side, but it was an absolute nightmare politically and financially, and I need to thank the grants people, Sadisha and her team, on my team side, Emily at GSID, and particularly Danielle Ferris.
Francois, we're going to have to move on. I'm sorry.
Thank you.
Thank you very much for a really terrific presentation of very complicated data, but unfortunately, I know there's great interest in the study, but we're out of time because we have one more presentation, and in fairness to the final presenter, we'll need to move on. So let me now introduce, excuse me, too much paper here, Roland Landman from the ANRS, who is going to talk to us about, thanks, the Quattro study, ANRS 170, 4 or 7 days maintenance strategy in antiretroviral treated adults with HIV infection, an open, randomized, parallel, non-inferiority phase 3 trial.
So, good afternoon, everybody, chairpersons. It is an honor for me on behalf of my colleagues to present to you the first results of the randomized non-inferiority trials ANRS 170 Quattro, which investigate a 4 days a week HIV treatment maintenance strategy. Improving the convenience, the tolerability, and the cost of antiretroviral therapy in virologically suppressed patients is important, in particular regarding 2 drug regimens and reduced daily treatment dose. Various studies have also tested a short cycle approach using reduced weekly ERV intake. 3 of these studies use a 5 days a week strategy with a efavirenz-based regimen. The ICAR cohort investigates a 4 days a week strategy using PI and NNRTI-based regimen with 3 consecutive days off. The results of ICAR were subsequently confirmed by our group in the ANRS 4D prospective pilot study, showing a 96% success rate at week 48 in 100 patients. All these studies show over 90% efficacy, but their small sample size and the limited study power prevented them from demonstrating non-inferiority. In addition, there is no experience with the most widely used molecules, integrase inhibitors. So we designed the Quattro study to investigate the non-inferiority of a 4-day strategy, whether patients were taking a PI, an NNRTI, or integrase inhibitor-based triple therapy regimen. During the screening phase, the most important inclusion criteria were viral load under 50 copies for more than 12 months, no genotype resistance, and CD4 cell count above 250. You can see on this slide the details of the follow-up. All the patients from both arms who achieved the primary endpoint at week 48 currently continuing the trial exclusively on the 4-day regimen until week 96. So today we are going to share the results of the primary endpoint at week 48. The last patient achieved this endpoint in March of this year. As you can see, we have several sub-studies planned. So Quattro's main objective is to investigate the non-inferiorities of a 4 days versus a 7 days regimen using a 5% non-inferiority margin. The primary endpoint is the proportion of patients with therapeutic success defined by no virological failure and no strategy interruption, except for pregnancy or switching molecules between the same drug class. Selected secondary endpoints at week 48 are virological failure, viral resistance, and residual drug plasma concentration at the moment of failure, as well as safety and tolerability. The statistical analysis of the primary endpoint include an intention to treat and a peer protocol analysis using the Kaplan-Meier method, as well as snapshot and sensitivity analysis. In addition, we also carry out a subgroup analysis for virological failure according to the third adjunct class. Thanks to the effort of patients and our colleagues in 57 French clinical centers, we screened 850 patients in only 4 months. The most frequent reason for non-inclusion was resistance to a current drug or no complete genotype available. Finally, 318 patients in each arm were selected for the intention to treat analysis. 313 and 310 respectively were selected for the peer protocol analysis. So the results, no, sorry, come back. So, yeah. So baseline characteristics were well balanced between both groups. The population was 49 years old in median, 85% were male, 78% were of European origin, 67% were MSM. They had a long therapeutic history with a median treatment duration of 6.9 years. Median duration of viral suppression was 5.8 years. The median CD4 cell count at screening was 689. The baseline NRTI was TDF or TAF and FTC in 73% of the population. 48% of the participants were on integrase inhibitors, 47% on NNRTI, and the others were on PI. So, the results of the primary endpoint. The primary endpoint showed a very high therapeutic success rate in both arms, 95.6% in the 4 days arm and 97.2% on the 7 days arm. Therapeutic success was non-inferior at the 5% margin in the 3 analyses. Virological failure in each arm was 1.9 and 1.3% respectively. As you can see, the 4 days arm was non-inferior using the FDA recommended 4% margin for maintenance therapy trials. The analysis of virological failure according to the third agent class show no significant difference between the groups. Other analyses show no statistical difference based on CD4 nadir, duration of viral suppression, prior virological failure, or CD4-CD8 ratio. As you can see, 6 cases of virological failure occur in the 4 days group and 4 in the reference group. With regard to non-virological failure, 2 deaths occur in the 4 days group, 1 from sudden cardiac arrest and the other from lung cancer. The number of patients who decide to end participation was quite similar in both groups. In this slide, we see a detailed description of all the 10 virological failures. You can find all the detail of this complex slide on the conference website. But just to mention some points. Among the patients with virological failure in the 4 days strategy, 3 had documented resistance to current treatment. 2 of these were on rilpivirine and 1 on raltegravir-based regimen. Among the 7 days arm, resistance appeared in 1 patient on rilpivirine. All these patients, except 1 in the 7 days arm, subsequently achieved suppression at their last visit after modification of strategy or modification of the treatment. During the follow-up, the number of blips, During the follow-up, the number of blips was remarkably stable in both arms, 13 in the 4 days arm versus 70 in the standard arms, with no statistical difference between both groups. No difference was seen between both arms during 48 weeks with regard to the evolution of hepatic or lipid parameters or weight, with the exception of a slight but significant improvement in eGFR in the 4 days arm, both for TDF or TAF-based regimen. No difference was seen with regard to CD4-CD8 ratio evolution from baseline. Analysis related to adverse events showed no difference between arms for adverse event grade 3 or 4, deaths or discontinuation. In conclusion, after several previous cohorts and pilot trials, the INRS Quattro randomized trial demonstrates the non-inferiority of a 4 days a week HIV treatment strategy versus the standard 7-day strategy, whatever the third agent class. Of course, the extended survey to understand long-term efficacy at week 96 is still ongoing, and as shown earlier, other sub-studies include comparison of adherence, viral load in semen, residual viremia, HIV total DNA, and inflammatory markers are planned. With the pharmacological sub-study, we hope to better understand the reason for the effectiveness we found in this regimen. Is it due to a true or long drug half-life in plasma, due to the persistence of intracellular efficiency, or maybe viral latency during the 3 days interruption? We believe that this 4 days a week regimen with 3 consecutive days of treatments offer patients and physicians a new maintenance therapy option. We must also remember the large economic impact of this strategy, a 43% reduction in ERV intake and cost in high-income countries. In addition, maybe the possibility of more patients accessing HIV care in low-income countries. I would like to thank everyone to contribute to the success of the study. Many thanks especially to Dr. Pierre Detruchy, my friend and a co-PI, to all the great team of biostatistics, Lambert Assumu, Jonathan Bellet, Dominique Costagliola, to the EMA team. We did so much to set up the coordination and monitoring of the trial. All of my colleagues, virologists, pharmacologists, immunologists, the DSMB members, Professor Pierre-Marie Girard, the President of Scientific Committee, and of course, the French NRS agency, Professor François Dabis, and all the team for the support. Finally, many thanks to all study participants, the TRT5 Patient Association, ICAR Association, Dr. Jacques Lepovich, and all the investigators and their staff. Thank you very much. Merci beaucoup, and muchas gracias.
Thank you very much and congratulations on a really very interesting and robustly conducted study. We're going to only take questions from the people currently standing at the microphone because we're going to run out of time for the session. So we'll start all the way over to my right.
Hi, Pablo Tebas from the University of Pennsylvania. I guess your study proves that our current regimens have forgiveness. Can you tell us how, did the study provide the treatment, or the study asked the patients just to stop taking medicines for 3 days? If that is the case, how do you know that the people that were randomized to 4 and 3 days were actually doing that? Did you do any pill counts, or did you do anything to confirm that they really were adhering to the strategy?
Yeah, of course, it's a major question. No, we're waiting for the PK studies on plasma concentration of tenofovir and the third agent for all the patients during the follow-up, first of all, the patient questionnaire. And of course, we check the regimen of all the patients after in each delivery of the drug. But they take the ongoing treatment and they stop for 3 days or maintenance of 7-day regimen.
Did you do pill counts or anything?
We make the pill counts, but I can't show the result for the moment. We are going to explore this with all the data together.
Next question.
Hi, Laura Waters from London. Thank you. I accept your number of virologic failures was small. However, all 6 failures in your 4-3 arm were from what we'd consider low barrier regimens, and half of them failed with 2-class resistance, compared to your 1 failure of your 4-triple with single-class resistance. So with that in mind, do you think you can really apply this to all triple regimens? Is rilpivirine really suitable for this strategy?
Yeah, of course, the protocol was built on the third agent class, not on each drug. It was impossible to build. It's not powerful to do that. So, but I agree, we have to fix our attention that the resistance occur in low genetic barriers drug. But it was a number of failure on rilpivirine are quite the same on the 7 days a week and the 4 days a week regimen, in fact.
Next, Tony.
Tony Mills from Los Angeles, and I think my question is similar to that. And you did the class analysis and didn't show any difference between the classes, but did you look at individual agents, or are you going to hone down and do that to see if that was the difference?
We are going to do that with the PK study together.
Thank you.
Thank you.
Final question.
Simon Collins from London. I think you have to be incredibly careful before you suggest that a study in a high-income setting can produce results that can be used in other settings. I don't think your results, your final conclusion, you said you were pointing to potential benefits in low-income settings. I don't think you can take a study that's done in France with high access to all sorts of monitoring and closer monitoring and viral load and resistance tests and imply that this can be transferred to other countries.
Yeah, I totally agree with you. We are not going to say that we need to use this in the developing countries. We have to perform other studies, of course, and to be sure that it will be done. But with the use of high genetic barrier drugs like dolutegravir in South, I think that we can perform this kind of studies.
Thank you very much. On behalf of my co-moderator, Chloe Orkin, I'd like to again thank all of the presenters for some really fascinating data, and thank the audience and enjoy the remainder of the conference.